Hello everybody, my name is Seper Zairin. I work in France. I am specialist in zygomatic implants. My specialty for the last 20 years is the immediacy for full arch rehabilitation with grafting techniques or without grafting techniques. So for many years I stopped grafting full arch rehabilitation and I'm using zygomatic implants only for full arch and in order to have immediacy and a fast treatment. So my case today is to talk about one very common situation. It means a failure. This first case is Mr. L, 72 years old and with a good general health, non-smoker, but the implants failed after 2 years. And you can see on the slide that we are a huge bone loss and gingiva loss too. For this kind of cases, it's very difficult to put immediate implants because if we try to do it, we will have a problem. We will have a problem because we don't have keratinized gingiva. So the treatment planning we have are two options. First, the grafting solution. It means after removing the implants, we have to do a complex bone grafting all over the maxilla and double sinus lift, waiting 8 months, putting the implants, waiting 6 months to have a definitive fixed prosthesis. It means a very long-term healing period, and it means a very difficult period for the patient without teeth, because we cannot use the removable prosthesis on bone grafting. If not, the bone grafting will fail. So it means a very difficult situation for the patient, for the social and professional life. So the second option is better for me. I believe in this second option because with 4 zygomatic implants, we will solve the situation. I mean, after removing the implant, we can screw 4 zygomatic implants during the immediate loading. So it means for the patient having a fixed prosthesis in the very same day. And it's fantastic for the social and the professional life. And after 6 months, we can screw the final prosthesis. So let me show you the treatment planning and the planification. Of course, we start with pictures, with 3D images, in order to have the situation before starting the surgery. The digital workflow helped me to have the end in mind. I mean, I know before the surgery what would be the final situation, the final proposal for the patient and for the aesthetics. And it's very important to be able to know with the end in mind if we need to have artificial gingiva or no, if we have a huge bone resorption or no, and the pictures will help us with the 3D images. And we can match pictures, 3D images, and with the planification and with Smile Design to know the aesthetic situation for the final prosthesis. So let me move on to the next slide. It means we have to remove the implant first because we need a healing period for the gingiva to create a keratinized gingiva again. Because if not, we will have many problems and failure. It means if we start this kind of cases, we remove the implants and we put the immediate implants, the problem will arrive a few months later. I mean, dehiscence, infection, or many other problems like periimplantitis. So we need this keratinized gingiva. So we need to wait to create again this keratinized gingiva. So the digital workflow helps us to have the situation and to be able to create a removable prosthesis with the same planification. So after removing the implants, we can give to our patient a removable prosthesis with the same design of the teeth, with the same aesthetic planification. And after 2 months, we have this kind of situation. We need to remove another implant, of course, in the mandible too. And you can see in the 3D images, we don't have bone. And of course, we can graft, or we can use the zygomatic implants using the zygomatic bone, I mean the native bone, so it means something very strong to be able to do the immediate loading on the same day. After 2 months healing period, we have this very nice keratinated gingiva. The situation is not the same now. It's another story. We have keratinated gingiva, we just have to manage the bone. And my particularity is to work in local anesthesia, under local anesthesia without sedation. So we are doing the surgery freehand. I raise the flap on one side, treating this one side, finishing. With the Straumann zygomatic implants, I'm very happy to use them because I can adapt the anatomy of my implant with the anatomy of the patient. I can choose the right tool for the right situation. So in the posterior side, I'm using the round design. In the anterior side too, for this side, because we have bone around the platform of the implant. And as we are under local anesthesia, I can check all the time the occlusion and to be sure that the occlusion will be correct and the screw hole for the prosthesis will be correct. We remove the last implant in the maxilla, and on the right side of the patient, we don't have bone on the crestal part. So we are using a flat design to have a fantastic stability, and we end our surgery with the impression with the intraoral camera. And after the surgery, we are matching the impression before the surgery and at the end of the surgery. And now we are able to create a provisional temporary bridge and fixed bridge. The fixed temporary bridge is milled in PMMA, and of course, makeup is done. And the result is very nice because we started with the planification first. So the OPG after the surgery, of course, we remove the implant and the mandible with the peri-implantitis too. And we have this fixed temporary bridge perfectly screwed on the maxilla. It means for this patient, in one day, the surgery was during the morning under local anesthesia, freehand. The surgery lasted 2 hours and a half, and everything went very smooth. And we had a very nice stability for each zygomatic implant because of the design of this implant. And I can be fast for this kind of surgery because the drill is very fast and effective. And the diameter of the implant is a small diameter. So it means I just have to use one drill. Now we can see the 3D radiography just to check it out, to be sure to have a right space between the two implants. It's very important to have a nice AP distribution, a right AP distribution between the anterior implant and the posterior implant. The implants don't have to be too close, and we have to create a space between the two implants. So it means to have the anterior implant in the position of the lateral incisor and the posterior implant in position for the second premolar or first molar. And now the prosthesis is screwed and the patient can smile again with fixed teeth. And that was the planification first, with the smile design, and of course the result is the same. That's how I'm using digital workflow. The digital workflow doesn't help me for the surgery because I'm doing everything in freehand, but it helps me for the prosthesis. It's very important for me to know before the surgery what will be the result at the end of the day. So, if you have to talk about the implant and why these tools are very helpful to me. We have two designs of implants, round and flat. Round implant is when we have enough bone around the platform of the implant, when the crystal part is not tiny. So, if we can have enough bone around this implant, we can use the round design. If we don't have, we will create a channel to have the implant as submerged as possible, and the flat design will be very helpful to avoid an overextension of the body of the implant. And all the design is perfectly adapted to each situation. I mean, one part is a machine surface to avoid an invasion of the bacteria. The rough surface is the part into the bone, into the zygomatic bone, but the apex is round and smooth to avoid the skin irritation or bacterial invasion. So it means every part is perfectly adapted. Like a chess player, we have one step ahead, and I invite you with the link to go to this article and to read this article with all the explanation for each part of the implant. Thanks a lot for your attention, and I hope I add something to your existing knowledge.